cross-match.
Excellent.
If you are changing your lot number of single antigen, or you change calibration of your machine, something major need to force you to do re-evaluate your cutoffs.
Dr. Ahmed Adel Hassan, please.
Ask you?
I'll try my best to answer you.
Just if you have a patient with a negative CDC and flow cross match, and then he develops specific antibodies, I mean donor-specific antibodies, acute rejection. What's his explanation?
Well, the CDC negative, flow cross match positive.
No. CDC negative, flow cross match negative, and you transplant, and still the patient develops antibody-mediated rejection.
Very good. So remember, in the risk stratification of patients, you might come across a subgroup as you work them up for sensitization that they will have positive HLA antibodies by the solid phase immunoassay only, the Luminix single antigen, and they will have negative flow cross match and CDC. So if your program, for example, does not look into single antigen testing, if your program depends, for example, on CDC primarily, you might, in fact, overlook a few patients that they can go for transplant with a minor risk for antibody-mediated rejection, specifically those that will be tested negative by CDC. If you don't do flow and you don't do single antigen testing, you might have a category of patient that will be both positive by single antigen as well as by flow. If you do flow and CDC cross-match, you might have fewer patients that they would have antibody by solid phase immunoassay, but negative flow and CDC cross-match. And those patients still at risk of AMR if they go for transplant without manipulation, without some degree of desensitization. So this group of patients, either your flow methodology somehow is not sensitive enough. For example, as Fadi mentioned, if you don't use pronase as a standard in flow cross-match, you might be having somebody with negative flow cross-match, but in fact, if you do the pronase, it might be positive, and that positive pronase-treated flow cross-match might be due to donor-specific antibody. The bottom line, if you want to characterize your patient fully before transplantation, and if you want to minimize the risk of AMR, in my mind, I think the three methodologies have to be done, especially if the patient happens to be sensitized, and that includes CDC, flow cross-match, and single antigen testing. Now, the beauty of single antigen, remember the flow cross-match is a non-specific. It can tell you about complement fixing and non-complement fixing antibodies. It doesn't tell you about whether these antibodies are complement fixing or not. And it could be non-HLA antibodies. It could be just simply an antibody that is not HLA. But the beauty of combining flow with single antigen, if the single antigen is positive and the flow is positive, you control for auto cross-match and other non-HLA antibody, then your flow cross-match is most definitely caused by your HLA antibody that you detected by HLA testing, by single solid phase immunoassay, and therefore you have to plan some form of desensitization before they send the patient for transplant. So to answer you very briefly, most likely your patient who went to transplant with negative CDC and negative flow had low titer donor-specific antibody that was only detected by solid phase immunoassay, but you did not have that done, and that led to AMR after transplant.
Also, an important question to the patient himself: was he really compliant with his medication, especially when they are teenagers? This is really something common.
Yeah. Okay. More questions. Lady in front? No?
Any significant role for anti-inferior antibodies in solid organ transplant?
Very good question. We see, in fact, if you cover HLA antibodies, you are covering more than 95% of antibodies that causes AMR. But that does not mean that there is no role for non-HLA antibodies. One example of which is the anti-endothelial antibody, as well as the MIC-A and some antibody against the angiotensin receptor 1 have been reported sporadically to cause AMR. But I think in the bulk of practice, if you concentrate on HLA antibodies and how to characterize them best with the method that we just told you, I think you'll be minimizing tremendously the risk of AMR after transplantation. Yes, at the back, please. Yeah.
So you all mentioned that vaccination affects the HLA antibody test. So I would like you to tell me which of the approved vaccine right now induce this false positivity that if you have a patient that have this positivity? Thank you.
I can tell you about, thank you for the question. Now, one of the approved vaccination that we use frequently in transplantation is the flu vaccine. You know that it's given annually, and it has been clearly shown in recent publication that the patients who are vaccinated after transplant with the flu vaccine develop antibodies, HLA antibodies, after the vaccination. Now, nobody knows exactly what will be the long-term impact of this HLA antibody development on them down the line, but certainly it's a call for concern. We have to be concerned about this phenomena that people who have not been HLA sensitized, being vaccinated by flu vaccine, and at some time in the future they develop antibodies. Now, it's not only vaccination, as my colleagues mentioned, and as I mentioned earlier, infections play a major role, especially CMV infection and other bacterial infection. And most people believe that, remember, HLA is a protein, so it's shared that HLA cross-react with some of the protein component of the bacteria or the virus, and therefore it has been conclusively demonstrated that if you are HLA sensitized and your titer of the antibody came down, but if you are infected, all of a sudden your antibody, among many other HLA antibodies, goes up after the infection. Once you control the infection, the antibody comes down. So there's no question that vaccination is something to watch for, especially in sensitized patients. Now, but specifically going back to the question of influenza, we don't know exactly. People don't know yet what will be the impact of this, but if you have HLA antibody, and if you happen to be from the school of thought of the humoral theory of transplantation, those antibodies, if persist over time, they will cause injury, especially in high concentration. More questions, please. At the back, yeah, in the middle. Thank you.
Thank you very much, all of you, for your presentation. It was really, I benefited a lot of it. But since we are in GCC, and I'm asking this question as a citizen of the GCC, and because King Faisal is one of the leaders in transplantation, what we have done to tailor our test methodology in GCC to fit up our genotype and phenotype. Clearly, Muhib said the beads are coming from the West, from Europe, and some of these antigens on them, the HLA particles are somehow relevant, some of them are not relevant because of the difference in the race. So is there any, Dr. Shaheen, anything we are doing within GCC, within King Faisal, to improve and tailor our test types to match our race, to match our area?
Thank you very much. I think the best man to answer this is Muhib and Maha, but I can tell you, first of all, I'm not Shaheen. We look alike, me and Shaheen. I'm a good friend of him. What you're asking for is an effort. Let me just jumpstart the answer by saying it should be an effort really at the SCOT level. I think SCOT, the Saudi Center for Organ Transplantation, should take a leading role in trying to standardize this kind of testing across the GCC countries. It should not really be, in my mind, a single center effort. Muhib, would you like to add?
Yes, it is two parts actually. One is the haplotype frequency and one the HLA allele frequency. We are in the process, inshallah, in the near future to have it done. We have one part done, the second part we are working for it. It's need a lot of money, especially if we want to do it nationwide. This will tell us the allele frequency in Saudi population, but I don't think we will be able to composite our own single antigen panels. If you know, in HLA now, with all the labs and all the transplant, there is only 2 companies manufacturing. It's very hard and very difficult to really make it working very well. Unless you make your own factory, that's something else. But we are working on defining the allele frequency. Inshallah, near future, you will see it.
I think that your question is very, very good and very relevant. But again, I think the people to address that question too is the people at the Saudi Center for Organ Transplantation. Because really, if you're talking about any collaboration at the Gulf country states, and it's very important, especially since we share organs and so on, is really to address it at the body that is in charge of organ allocation and standardization of testing. Taib. At the back, please, yeah? I can answer that. It's very easy. You know, once you risk stratify your patient, and I showed the slide how do we do the risk stratification. If the patient happens to be sensitized, and we use the most sensitive technology available, that's the Luminex screening methodology, and happens not to have donor-specific antibody, and his flow cross-match is negative, and CDC is negative, then he goes for induction with thymoglobulin, and we go for maintenance immunosuppressive regimen of tacrolimus, CellCept, and prednisone. If he happens to be donor-specific antibody positive, but negative flow cross-match and negative CDC, in addition to thymo, he gets a small dose IVIG. Small dose IVIG defined as 1 gram per kilogram over 24 hours. If he happens to be sensitized with DSA, donor-specific antibody, and positive flow cross-match, he goes for the sensitization that includes, in addition to thymoglobulin, high-dose IVIG, which is 2 grams per kilogram, plus a single dose of rituximab, which is anti-CD20 antibody. Now, the highest risk category, as Fadi mentioned, is the positive CDC, along with positive flow and positive DSA. They go for the so-called full desensitization, which includes antibody depletion with either plasmapheresis or immunoadsorption, plus high-dose IVIG, plus rituximab, plus obviously the thymoglobulin induction and the maintenance immunosuppression of tacrolimus, CellCept, and prednisone. This is in summary the way we do it. Yes, sir.
About the rejection patient, if we want to follow up him, is there any special test we have to do it? I mean, what about CD30, soluble CD30?
I'm sorry, what kind of patient you're talking about?
The rejection patient, if we want to follow up some test, special test.
Yeah. If we're talking about all patients that we just included, those are the sensitized plus those with DSA plus flow cross-match plus positive CDC. The way we follow them after transplant is first and most importantly with careful follow-up by the clinical team. So those patients by definition are at high risk for rejection, and therefore they deserve much more scrutiny in their follow-up than the average patient who is not sensitized, who had better match, and so on. And the way we do it is by careful clinical follow-up. We sometimes do the single antigen testing, not really routinely on everybody, because I think our desensitization protocol is quite successful because we are very careful in selecting patients who are desensitized, and those who are not desensitizable, we put them in the paired kidney donation plan. So single antigen testing post-transplant periodically is one way. Protocol biopsy is another way of following them, because sometimes you discover many of these patients having subclinical rejection that you cannot detect by your routine testing. So in addition to single antigen testing, we do protocol biopsy periodically. Now, CD30 counts and so on, people have looked at it. To my mind, it's not really that useful tool as long as you concentrate on risk stratification, that is to follow patients who are really at risk for AMR, especially those subjected to desensitization. And the way the two most important tools, at least in our, or the three most important tools, careful clinical follow-up, protocol biopsies, and periodically doing the single antigen testing. Thank you. Yes, sir. In the middle? Yeah.
When you have your surgeon cutting open one of the patients, there is an inflammation release of cytokines. These cytokines will make B cells produce antibodies non-specifically. And desensitization events by surgery, by flu, by the other, not the most common, which is and strong, previous transplantation, pregnancy, they are not as strong as sensitization event and last for a long time as those. So with the flu, if someone with the flu and he is now showing an antibody reaction or positivity, we would ask him when he is not sick, we will draw another sample and test him. Most probably he will be losing those antibodies. So answer your question, yes. B cells, once they are faced with a lot of cytokines, they respond non-specifically. And this non-specific reaction could be against HLA, which we detected by Luminex.
Yes, please, the middle, yeah.
I bring a case for you. It is strangely happened in one they sent him to the X-ray to do oral swelling. And unfortunately, he went to renal failure after the. What is the reason? What is the cost of this?
I'm not sure I followed you. He went for what kind of surgery? I'm sorry, I was not hearing very well.
Gastro sleeve.
Sleeve, okay. And
they sent him for X-ray the second day for oral swelling X-ray.
Yeah.
And unfortunately, in the middle of night, he went to renal failure.
Is he a kidney transplant patient, or is he?
No.
Well,
he's young also, the patient.
But you know, this
But
workshop
from the oral swelling for X-ray to clear the operation, there is no leaking after the operation.
and developed renal failure after that. But how does that relate to our workshop of HLA? What is the relevance of that?
I mean, what is the cost of renal failure with this oral swelling?
Hassan Eid, he's our nephrologist in the audience. Do you want to answer that, please? Unfortunately, you know, I would like to focus on questions relating to HLA. So if that is related to HLA, I'll be more than happy to address. Otherwise, I can share that with you in the break, probably. I can tell you my belief. Yes, please, the middle.
Dr. Naqi Zafar from Pakistan. I really enjoyed this session. I just want to make a comment that the new solid phase assay perhaps has its most value in second transplants. Because when you have patients who have had a transplant before, prior to their transplant, if you're doing a CDC or a flow cross-match, you probably find them negative with a new donor. But if you do a solid phase assay, you would find low levels of anti-donor specific antibodies, and soon after transplant, they flare up and you can have an antibody-mediated rejection. Perhaps the most value of this sensitive assay is in those patients who are using secondary transplant. This is at least the experience that I have found in our cohort of patients in Karachi. Thank you.
Sure. Mohib, you would like to comment?
I agree with you. The use of Luminex will be for those who are really with a chance to have hyperacute rejection, those who are with previous transplant. So if you have very sensitive tool, at least then the physician will know that there is very small amount of antibodies. Please watch out. Please tell the patient to be very compliant with his medication, because any turbulence in his medication, if he's not taking it, he will really be in bad shape. And it happens.
Very good. Any more questions? Yes, please. Front.
In your post-transplant monitoring, how often do you test your patients for PRAs?
I was afraid somebody will ask me that question because, you know, nobody. I told you already that we are very careful, first of all, in selecting patients who are transplantable from the immunological risk stratification that we follow. Now, if we are to embark on testing everybody, whether desensitized or for de novo antibody formation, that antibody developed after transplant, and if you believe that those antibodies over time can cause injury, you can easily, at least on theoretical ground, pending more studies, and you know there are some ongoing studies that will hopefully shed more light on this, that everybody should be tested for de novo or to follow up somebody who had HLA antibody before transplant, what happened to them after transplant. The problem is the frequency of the testing and the cost of the cost involved will be quite prohibitive at the present time. Number one. Number two, what did you do with the data? For example, if somebody is doing very well, kidney function is great, you do his protocol biopsy, there is no rejection, but his antibody by single antigen testing increased from whatever MFI to whatever MFI. What does that mean? Are you going to do anything about it? And so this is the subject of ongoing study, and until we have the result of this ongoing trials, unfortunately we cannot really give any recommendation. Certainly you can select patients who are likely, for example, those high-risk patients that you desensitized, and focus on them to see what will happen to their DSA titer after transplant. But to advise it across the board for everybody, there might be some theoretical background, but until we see some evidence that this massive screening program will have any benefit in terms of graft survival, I don't think it's recommended to do that at the present time.
But if you allow me, Doctor.
Yes, please.
For other organs like heart and lung, we really recommend more frequent testing than renal. Especially for heart, we recommend more than one time first year, then once every year. And we have seen people coming to, Fadi saying every month, which is really possible. They come to the OR with bad echo results, and when we test them, we find antibodies, anti-HLA antibodies. So at least if we can catch the antibodies before they really deteriorate, that will be very, very nice for them, especially for heart and lung. With kidney, it is more flexible in this particular area.
I think, yeah, for the other solid organ, your question was about kidney, yeah. But for other solid, there might be a role. But then, even when you have the positive testing, you have to follow it up with more testing to decide if that DSA is doing anything harmful to the organ. And remember, the heart and the lungs are life-saving procedures, so we should do every effort to maintain them as long as possible. But we have time for 2 more questions. Any from the ladies? Yes, please. To Janet.
And my voice is high. What about those non-HLA antigens? You know that they go for transplant with the non-HLA antigens. What do you do in your practice now? Do you follow them up with the protocol biopsy and like a titer or concentration level?
When you talk about non-HLA...
Because you know that there is evidence accumulating about even those although they are non-HLA antigens, but the outcome will be worse.
Yeah. Now, remember I told one of the other, I think, audience asked the same question about the non-HLA antibody. Now, you have the MIC-A and MIC-B, which is a gene system very closely linked to the HLA system, but it's not HLA antibody. And there has been some quite convincing case reports that antibodies against those antibody can cause AMR. But if you compare that with the incidence of AMR relating to HLA antibody, we're talking about very small, minute amount of patients developing antibodies as compared with HLA antibody causing AMR. So in that context, you have to type for your MIC-A and MIC-B, and as well follow the anti-MIC-A antibodies. Registry data as well has shown that those who develop MIC-A in registry data have deleterious outcome as compared with those who do not have MIC-A or MIC-B, although in the registry you cannot say whether these MIC-A or MIC-B are donor-specific or not. Now, the anti-endothelial antibodies, and you know there is a commercial assay available, XM1, that people talk about. It's still not really very convincing. Some reports an increased incidence of both cell-mediated rejection as well as AMR in patients who have positive XM1, which simply denotes antibody directed against endothelial antigens. And so this is one thing that you can implement to follow up these patients. And finally, there's very uncommon kind of antibody that targets angiotensin 1 receptor. There was only 1 or 2 publications. The first one came in the New England Journal of Medicine, where they reported somebody with severe hypertension and antibody-mediated rejection after transplant. And it turns out to be antibodies directed against angiotensin 1 receptor that the endothelium expresses. But I think for the everyday practice, I think in the HLA lab, if you focus on HLA antibody and try to, we can tell you this from our experience. We're very proud to tell you that our incidence of AMR, despite that we do many high-risk patients, whether desensitized or non-desensitized, is very low. And we owe it really to the excellent work of our HLA staff in the HLA laboratory, because with the technology that we have, we are able to measure all different kind of concentration of HLA antibodies. And on the other hand, from the clinical side, we have a way to address the needs of these patients once these antibodies are measured. And with that, our AMR, despite that we do many desensitized patients, is really very, very low. If you want to expand it to the 100%, then definitely you have to think about ways of measuring anti-endothelial antibodies, MIC-A and MIC-B typing and antibodies, as well as, if you believe in the angiotensin 1 receptor antibody, those you have to add them to your armamentarium of testing in the HLA.
But currently in your unit,
we don't do that. We don't do that.
Thank you.
Yeah. Yes, sir. The last question, because we have to go to lunch and.
Okay, I am Dr. Osama, senior intensivist from King Saud Hospital. I have a little bit general question. We usually face this situation, patient with transplanted organ like kidney, for example, and admitted with a case of severe sepsis and septic shock. And we come in situation where patient deteriorated, and we think to save the life of the patient, and we think also about the organ. The patient in this situation will be on immunosuppressive drug, 2 or 3 drugs like tacrolimus and others. And usually we have a big discussion with the nephrologist and the internist and we as intensivists. What do you think when we face this situation, we have 2 to 3 drugs? You have a special recommendation to stop 1 or 2, or use 1, or decrease the dose? What do you think about this situation? Thank you.
Good question. In fact, unfortunately, we face this situation frequently in our patients if they become ill and get septic and get into the ICU. In principle, the guiding principle in life comes first. So when his life is in jeopardy, then life will take priority over his organ. So there's no question that somebody is dying from sepsis, that you should stop his immunosuppressive medication and keep them only probably on cortisone, Solimedrol. Since you are intensivist, you know that Solimedrol is beneficial to patients with septic shock and sepsis and so on.
Yes.
And that will be enough probably to cover their needs for anti-rejection during the period of illness. And you stop, for example, the anti-proliferative agent or the cyclosporin or tacrolimus, the CNI, both together, and keep them on just, for example, hydrocortisone stress dose every 8 hours, every 6 hours while they are in septic episode. Once they get over their sepsis, then gradually you can reintroduce their maintenance immunosuppressor. But there's no question that when it comes to solid organ transplant, the same rule that applies to non-transplant patient, lives come first.
Yeah,
so you should save their life.
Thank you.
Thank you. So I think with that, if allow me to conclude, to have a break, I encourage you to attend the afternoon. It will be much more entertaining with interaction from all of you, including voting devices. And we encourage you to be an active participant in the afternoon session. We'll start sharply at 1:30 to allow enough time for lunch and prayer. Thank you very much. Okay, good afternoon. I think we should start. Bismillah ar-Rahman ar-Rahim. Thank you very much for joining us again for the second part of the workshop, which, as I told you, will be some case studies that we'll share with you. And it's really purely and simply an interactive session where we'll be asking you for your participation, not only in voting on the questions and on the answers provided, but as well as we'll have some discussion after each case to make sure that some of the concepts that we introduced early on today are really clearly present in your mind for your future practice. Now, in terms of acknowledgement, I forgot to acknowledge early on One Lambda for really sponsoring the voting devices that we are using it in our session today. And thanking Scott, the Saudi Center for Organ Transplantation, for asking us to participate in the Congress in conducting the workshop. And most importantly, all the staff of the HLA lab for their really hard work and for their participation in providing us with the material for this workshop. Now, one of the advantages of the keypad voting is that you don't have to be shy in answering, because nobody will know who answered wrongly, who answered rightly. And there is nothing called right or wrong answers. Starting with just knowing you, who are you? So the first question, just to make sure that the system is working, are you a physician, surgeon, HLA lab or pathology staff, transplant coordinator, a nurse, or other health workers? So the number that corresponds to your profession, if you please enter it now. Enter it now, please. Okay, very good. So we have a reasonable mix of 19 physicians, 13 HLA lab or pathology staff, 6 nurses, 1 transplant coordinator, and 1 surgeon. And the remaining 2 are other health care workers. Very good. Okay. So the first case. Now, based on the principle that we shared with you this morning about the HLA testing, those cases are carefully selected to address whatever has been presented by my colleagues and by myself early on, to try just to make sure that we clarify those principles, those concepts by examples. So the first case is a 55-year-old multiparous, for those who don't know, multiple pregnancy, who received multiple blood transfusion and developed end-stage renal disease, a female, who is undergoing workup for listing on the cadaveric waiting list at your center. Now, we told you that one of the way of testing the sensitization of any candidate for listing or for a living donor kidney transplant is doing the PRA. And in this example, the PRA was done several times on her, and it was done by the CDC methodology, and it was reported as anywhere from 0 to 6%. The questions: which of the following statements best describe her HLA sensitization? Number 1, she is not sensitized. Number 2, she has more than 94% chance of receiving a flow cross-match negative deceased donor kidney. Number 3, she could be sensitized and further testing is needed. And finally, virtual PRA can be predicted from the available information. Now, I need to make sure before we pass the vote, we enter the answers, to make sure that you understand. If there's any question about anything, please ask now before we move to the answers part. Any questions about the case? Yes, Abdel Nasser.
Yes, she could be sensitized because...
No, those are the answers. Now, but any questions about the information provided?
Information? No. Don't answer.
Don't answer it now.
Okay.
Any question about the information provided? So if everybody is clear in his mind about his right answer, whether it's number 1, that she is not sensitized, number 2, she has more than 95% chance of receiving a flow cross-match kidney, or she could be sensitized and further test is needed, and virtual PRA can be predicted from the available information. If you are clear in your mind about the answer, keep that in your mind as we move to the voting slide, which is the next slide. Everybody is clear about his answer in his mind? Just make sure that you are clear about your answer, whether it's 1, 2, 3, or 4. Ready? Ready, okay. So enter your vote now, please, whether it's number 1, 2, 3, or 4. Very good. So we have the bulk of the audience is in favor of C as the right answer. And C again is what? What was C? Excellent. So I think we have very highly educated audience, and considering the mix, I think this is a very good answer. Now remember, we told you that the sensitization in her case was measured by CDC, which is the least sensitive way of measuring sensitization. It's the standard basic one that Terasaki used in his seminal work in 1969. And this is the technique that you heard about, whether you are doing it for actual cross-match, when you have a donor lymphocyte, or when you are doing it for sensitization using a panel of donor lymphocyte that are randomly selected to represent the local population. And Dr. Muhib already explained to you the way we measure the positivity. So if you have none of the wells in the panel is reacting, so no cell death is reported. So this is correspond to 0% PRA versus, for example, 6% PRA versus 100% PRA. That's the way the CDC PRA is done. And the PRA concept was already introduced by you, and for us as clinician, it's useful to use it for what we call transplantability index. That is to say, what are the chances, as Muhib already introduced to you, that this patient who has, for example, 5% PRA, that he will receive a cross-match negative CDC kidney. And if he is 5% sensitized, then we're talking about 95% chance of receiving a kidney. That is negative. Now, as it turns out, with the other testing that we introduced to you, and especially the solid phase immunoassay, the sensitivity of measuring antibody improves or increases as you use more of the advanced technology. For example, if you look at the study that measured sensitization by CDC in one part, you can see that out of 200 plus serum sample tested, only 102 sample were positive by CDC. When you enhance the sensitivity of CDC by Hg, this increases to about, so you are detecting about 14 more samples that were failed to be detected by CDC. And as you use the flow, you are detecting even more samples that were tested negative by CDC and HCCDC. And certainly, the solid phase immunoassay is the most sensitive, and your chances of picking up antibodies that were not detected by any of these three methodology improves. And this diagram, just to show you the sensitivity of measurement of HLA antibody, depends very much on what assay you are using. With the Luminex magnetic bead assay is the most sensitive way of measuring HLA antibodies. I think the analogy of the iceberg is very useful, because if you look at the sensitization with CDC only, and as Fadi told you, CDC measures really the antibodies if they are in high titer, you are looking only at the tip of the iceberg. But beneath the sea surface, there are many, many patients who have lower degree of sensitization that you can only detect by using the most sensitive technique, in this case, the solid phase immunoassay. Now, frequently, many of us get confused about what we mean by cross-match and titer, and those are two completely different definitions. PRA, you already know what PRA is. The cross-match is completely different. The cross-match titer is completely different. The titer measures the concentration of the antibody in the serum, and they do not correlate necessarily with the PRA. For example, in this study, as you can see, even if you have somebody with 80% sensitization, meaning that he's really broadly and highly sensitized, for his respective donor, the cross-match was below 1 to 4. If you just correlate the degree of sensitization to the degree of, to the titer of the antibody, you should have, with more sensitization, more antibody titer, but that does not follow. So the titer is something completely different from the degree of sensitization. And sometimes, especially now with the solid phase assay, we showed you an example of readout already, that you can have somebody who is really sensitized to many, many HLA antigens, in this case class 1A and B. But the titer or the strength of this antibody is very low. So this patient, if you want to follow the PRA philosophy, he is broadly sensitized to many HLA antigens, but this degree of sensitization is not high. Many of these antibodies are not strongly reacting antibodies. So you can be broadly sensitized, but not necessarily having a very high titer antibody for which you label this patient as not likely to receive a kidney transplant, versus somebody who has reasonably high titer antibody, but it's limited to a very few number of HLA antigens. The virtual PRA was beautifully presented by, and virtual cross-match by Fadi. And certainly, if you want to do virtual cross-match or virtual PRA, then the information provided to you in this example does not allow you to do so, because we have to tell you about the antibody specificity in the serum of the patient, number one, and the HLA typing of the potential donor for which he is donating a kidney, in order for you to predict the virtual PRA, or the other donors, not necessarily one donor, to talk about virtual cross-match or virtual PRA. We talked about the calculated PRA. We don't have to spend much time on it. So that's very good. Now we'll move to the second case study. The second case is a 42-year-old, again, multiparous female with end-stage renal disease who had developed end-stage renal disease secondary to lupus. So I'm telling you about a lady who is exposed to sensitizing event, being multiparous, and has lupus as a cause of her end-stage renal disease. She is undergoing workup for living donor kidney transplant. Flow PRA was negative for class 1 and 2. So we have one of the most sensitive technique of measuring PRA that gave us a result of negative screening for class 1 and class 2. Now HLA typing of the patient is shown. And what I'm showing you as well, the typing of the donor with the mismatch antigens highlighted in yellow. So this donor happened to be mismatch at the B locus, B58 as compared with B50, CW3 as compared with CW15, and CW6 again with 15, and DR3. So in this example, we have 4 antigen mismatch with that donor. Remember that the angle of the triangle of the HLA work, sensitization, typing, and cross-match. We have the cross-match, in this case, done by flow, and it was reported as positive T cell, but negative B cell. Is that clear? Any question by the case? Okay, now the questions. Faced with this information in your center, your next step should include request a T cell CDC cross-match, add HLA1, a class 1 single antigen by solid phase immunoassay, ignore the positive T cell flow cross-match as potentially due to auto-HLA antibodies, and finally request an auto cross-match. Any question about the case before we move to the voting? No questions? Okay. Now, if you are clear, if you are clear about your answers, whether it's 1, 2, 3, or 4, 1 is request a T cell CDC, 2, HLA class 1 single antigen by solid phase immunoassay, 3, ignore the positive T cell as potentially due to auto-HLA antibodies, and finally request a auto cross-match. Are you clear about your answer? Okay. Place your vote now. 1 to 4, or A to D. Now, please. Very good. So we have the bulk of the people are in favor of C, which is ignore the positive T cell as potentially due to auto-HLA antibody, and the other group asking for auto cross-match. The most correct answer was really to request an auto cross-match. Remember, we gave you a clue that she has autoimmune disorder. This is lupus. And with autoimmune disorder, there's a huge tendency to develop autoantibodies that can interfere with your cross-match assay. So when you have somebody who is likely to have autoimmune disorder and you have a positive cross-match, worry about that. That's number 1. Number 2, remember from the presentation of Fadi that when we gave you the cross-match results, we told you that she is not sensitized by one of the most sensitive assay, flow PRA, so she does not have HLA antibody against class 1 and class 2. And more importantly, the T flow cross-match was positive, but the B flow cross-match was negative, which does not make immunological sense. As you know, HLA, if it's class 1, it's expressed on both T and B lymphocyte, and the density of expression is much more on B lymphocyte than on T lymphocyte. So for low titer HLA antibody, if the T cell is positive, the B cell should be positive as well. So we have several clues. The first one comes from the fact that she has autoimmune disorder. Number 2, that she is not sensitized. And number 3, that the T cell flow cross-match was positive and the B was negative, to highly suggest that this positive T cell cross-match is not due to HLA antibody, is due to auto antibody. And in fact, as you do the auto cross-match, you can see that significant part of the allo cross-match reactivity on the T cell was due to auto antibody. Can you please push the microphone so we can hear you? Yeah, just...
Isn't the autoreactivity considered as a part of QC when we run CDC? So this is one of the primary results we will get when we do CDC. It will not be...
Sure. So you can't... But instead of adding you already have the flow cross-match. You already know that she is not sensitized. And you have the flow cross-match result. The most... or the least expensive way of verifying this is by running auto cross-match on the flow. If you run the auto cross-match, you get your answer right away, because the channel shift, which is, let's say, 100 in this case, was mainly contributed for by autoantibodies. You can do the same thing with CDC cross-match, but there's no need to run the CDC cross-match because we are giving you a clue that this kind of cross-match does not make sense. positive T, negative B without evidence of sensitization. Okay, yes, please. Yes, we do that, and there will be some cases to address that particular part. If you want really to look for any degree of sensitization against any of the HLA loci, so definitely you have to type for A, B, and C for class 1, and for DR, DQ, and DP for class 2, because it has been clearly demonstrated now. We have enough evidence to say that antibodies directed against any of these antigens can cause AMR. So if you want really to fully characterize and stratify your risk for your patients, definitely typing for C is needed. Any more question about this case? I'm sorry?
For the C locus in both bone marrow transplantation or solid organ transplantation?
Fadi, you want to address that for bone marrow?
mean the importance of that locus?
Yeah,
of course, yeah. The matching, as you might see mismatch, and C locus could be recognized by the immune system lead to GVHD. So,
in solid organ or?
In the matter of solid organ, patient can produce antibody against C. That might have also AMR. Bone marrow, also it is important. We look at it. Yeah, I know there are like some cases they don't consider looking significance of the C locus, but we do everything for the bone marrow.
Muhib, if I get your question, you are asking why we do C for solid organ transplantation. We do it because a large percentage of our patients is sensitized. So from the get-go, we do ABC, DR, DQ. And most of the other centers, they do ABDR low resolution. For us, we do class 2 high resolution as well, because most of our patients is highly sensitized. Not highly, sensitized to highly sensitized. Just to smoothen the process, we are doing it all for C and DQ.
Very good. Any more questions about case number 2? Very good. I think you're doing very well. Excellent. Now we'll move to case number 3. 44-year-old sensitized end-stage disease male is being prepared for living donor kidney transplant. The flow PRA, again, one of the most sensitive way of measuring sensitization, was reported as class 1 negative, but class 2 positive. HLA typing, I'm showing you the typing here, and again, the mismatch antigens are shown in yellow, underlined as well. So he has one mismatch in A locus, one mismatch in B locus, and one mismatch in the DR locus. And for Ahmed Adel Hassan, we are doing the C typing, just to make sure it doesn't answer. Okay, so the T cell, to complete the full picture of the HLA, T cell AG-CDC cross-match was negative, which is the most sensitive way of CDC cross-match. However, the flow cross-match for T was negative, but B was positive. We did not do a CDC B cross-match. So we're looking at the B cross-match with the flow only. So this is the case. Any question? Abdel Nasser, any question? Okay. Sorry, Ahmed. Oh, sorry. No, DR, he is homozygous for DR3, so only DR3 there. Homozygous for DR3.
So we consider this as
mismatch, yes. Yes. طيب. Any other questions about the case? All right. Now the questions. It's obvious. The next question is what's causing the positive B cell cross-match? Is it class 2 DSA or low titer class 1 DSA? Is it non-specific binding of IgG to the FC receptor expressed on B lymphocyte? Could it be autoantibodies? And could it be all of the above? So, again, somebody who is sensitized to class 2 has been exposed to sensitizing events, and positive class 2 mismatch at 3 loci, including class 1, 2, and class 1, 2 antigens, and class 2, 1, reported by T cell AHG-CDC to be negative, but positive B cell cross-match by flow, but negative by T cell. And the answers are shown for you. Could that be class 2 DSA or low titer class 1 DSA, non-specific binding of IgG to the FC receptor on B lymphocyte, autoantibodies, or all of the above? Are you ready to vote?